So advanced illness, things are starting to move a little faster. There's that break point where you're not swallowing as well, you're spending more and more of the day sleeping, you're often nonverbal, you've forgotten how to talk, you've often seized up, and then you move into actively dying. Let's go to the next slide. Expected complications. As you're dying of your dementia, we know exactly what that's going to look like. You're going to breathe more and more shallowly, you're not going to cough, you're not going to clear your secretions, and we call it pneumonia, but it's really hypostatic chest congestion. You're too weak to cough, you can't clear that phlegm, you're aspirating a great deal of the time, and you're not strong enough to cough it clear. There's fever, you're dehydrated, you're not drinking. You're going to get a bladder infection or a chest infection. Your body's immune system is shutting down. Late dementia, your body's immune system shuts down. Families don't know that, but people with late dementia are very prone to infections. They have a diminished immune response, and you're going to have trouble swallowing. That's a defining feature of end-stage dementia, is that you forget how to swallow. And families need to hear that. I slip that in at the first or second care conference where I say, and at the very end, he's going to forget how to, he's forgetting how to talk now. He's forgetting how to walk. He's long ago forgotten how to dress or shave. He's going to forget how to eat. He doesn't know what to do with his knife now. He's still okay with a fork and a spoon. He's going to forget how to eat, and then he's going to forget how to swallow, and then he's going to go. And they need to hear that early. And they'll say, well, how do I know how much time they've got left? You'll see when he's sleeping more of the day, when he's got less and less energy, when he's less and less interested in eating, when he's less and less able to speak to you or express his needs, when he's no longer recognizing you. Those are all the things that you're looking for. Symptoms, they get short of breath, chest congestion, they have poorly controlled pain, it hurts to hold still. They get pressure ulcers, and we should talk about palliative wounds at this stage. It's really important that you recognize when a wound is palliative and that they're not dying because they've got an open wound and cellulitis in their leg. They've got an open wound and cellulitis in their leg because they're dying. Their system is shutting down. They have no arterial output. They have no forward perfusion. There is no oxygen getting to those tissues because their system is closing down. And if you're panicking about this leg wound and talking about transfer to acute and skin grafting, we're missing the boat. It's really important that we acknowledge this is a palliative wound. Your skin is breaking down. Your body's immune system is no longer healing. Your dad is dying, and he's got this open wound because his body's not strong enough to heal anymore. And stop chasing that medically and start treating that palliatively. And when we make that crucial decision, that crucial watershed, our treatment becomes far more appropriate. If you're young and healthy and you've just got peripheral vascular disease and this body of yours and this brain of yours are good for another 2 or 3 years, let's go for stenting, let's go for grafting, go. But if you're actually dying of your dementia, let's stop doing too much of the wrong thing. Let's make sure that we recognize and label for nurses and family, this is a palliative wound. Your mom's sacrum is breaking down because she can no longer heal. She can no longer fight infection, and she's dying. So it's important that you recognize that as one of the signs of end-stage dementia. Reduced appetite, weight loss. So what's our job in this? Our job is that we've seen this road 1,000 times. And family have never seen this road, and they have no idea where it's going, and they willfully deny. They don't want to know where this road is going. There's a certain amount of willful avoidance here. And it's our job to gently, quietly, make it clear that when Dad dies, not if Dad dies, not someday if he might, it's as your dad is dying. Let's have a conversation about what it's going to be like for your dad at the end of his process as he dies of his dementia. You need to know that there are some things coming that we're going to need to talk about. He's going to forget how to walk, he may fall, and he may break his hip. We need to talk about that. At the end, he's going to forget how to swallow. Can you elaborate on palliative care wounds? Boy, by the time they're necrotic and they stink to high heavens, debride or get your wound care nurse to debride. Use betadine, let it dry out if you can. Yeah, get it open, get the pus out, take the dead tissue away. And sometimes they'll survive, they'll pink up, it'll start granulating, and they just needed the dead tissue out of the way. Back of the heel, back of the calf. When it's stinking and weeping and oozing, You've got dead tissue in there in a closed cavity, and you have to open the cavity and let it all drain. And sometimes they'll recover. Sometimes it's peripheral vascular disease and the whole extremity is dusky purple. Not just dusky purple when it's been down for a couple of hours, but dusky purple even there in the bed elevated. You're dying. Their circulation's shutting down. You're dying in the next couple of weeks. Yeah. Yeah. Recognize the ones that you can save, whose body is healthy but their limb is necrotic, versus those whose body is actually dying and their limb is necrotic because they're dying of their end-stage dementia. Yeah. So where were we? So we know this road really well, and we need to walk people through that road and not take them right to the finish line on day one. We need to be gentle and introduce it a step at a time. At the first conversation, you can mention that most people stay in residential care for, they're in the last 1 to 2 years of their life when they come. In the middle conversation, the next time you meet, once you've got more trust and more relationship, you can start talking about the dying process. And I would encourage you to use the D word. There is so much denial and avoidance around passing on or going to a better place. And families are in so much denial that they might not even hear you. You think that you're spelling it out absolutely clearly about dad dying. Talk to families and they'll say, he never mentioned that. You have to use the word dying. And it's okay. And your degree of comfort, your inner acceptance of that will be a huge comfort to families because they're wrestling with their own acceptance. And if you can go there and you're just fine with that, then they're going to be more fine with that. You can help them enormously, emotionally, by being absolutely okay with the fact that dad is dying. And let's make that as rich and loving and comfortable and accepting a process as it can possibly be. Let's do a good death.